Hello and good morning, everyone. Aloha. Welcome to this Hawaii Care Choices Healthcare Talk Story. I'm Tish Fukushima, your moderator this morning. We have two wonderful guest speakers presenting today. Lani Weigert, Community Relations Manager for Hawaii Care Choices, and Harvard Medical School physician, Dr. Angelo E. Volandes, Associate Professor of Medicine, Massachusetts General Hospital, and a best-selling author of The Conversation, a revolutionary plan for end-of-life care. We are so excited that you are all joining us this morning on this beautiful Saturday. Before we start, I'd like to ask the audience, for those of you on Zoom, if you can hear me and see the PowerPoint that's on the screen, please give me a thumbs up. Okay, perfect. I see all of you over there. Aloha, hi. Okay, before we, excuse me, for those of you on Facebook, I want to say aloha to our Facebook ohana. Oh, I see more thumbs up. Perfect. Thank you so much, everybody. We want to let you know that today's Zoom meeting is being recorded so that you and others may access it in the future. To our Zoom participants, if you have any comments at any time, you may use the chat feature. And I see many of you are definitely utilizing that. Thank you. If you have any questions for either Lani or Dr. Volandes, please use the Q&A box at the bottom of your screen. For our Facebook users, please use the comment box to chat in any questions for our guest speakers as well. And feel free to share your reactions with us during this talk story using your reaction buttons. I'll be monitoring those as they come in. We are also doing polls today. So for those of you watching on Facebook Live, you'll not be able to engage in the polls. But if you want to join in the fully engaged Zoom presentation next month, please email lfukushima@hawaiicarechoices.org. But do not be ashamed if you would like to plug in your answer in the comment box. Feel free to do so as well. So polling is very simple. There's no right or wrong answers. A question will pop up on your screen. Please make the selection you think is best and submit your poll. So to kick things off, let's start with an icebreaker. All right, the icebreaker on your screen is, if you could have a superpower, what would it be? Would it be to read minds, become invisible, or be able to fly? Again, those of you on Facebook, feel free to plug in those answers. And the answer is either read minds, become invisible, or be able to fly. Perfect. We definitely got some people coming on in with their answers. And just take a few more moments. Wow, I just love it how everybody has had their coffee already and definitely knows what their superpower wants to be. If it was me, I think I would love to become invisible. All right, I'm going to end the polling right there. Thank you so much. And I'm going to share the results. So the question is, if you have a superpower, what would it be? 43% of you said you would like to read minds, 24% of you would like to become invisible, and 33% of you would be able to fly. Perfect. That is so great. And that's how easy polling is. So way to go, everybody. I know we just have such a smart audience this morning. Now I'd like to introduce you to our speakers today. We have Lani Weigert, who is the Community Relations Manager for Hawaii Care Choices. Aloha, Lani. Also joining us.
Aloha, everyone.
Also joining us this morning is Harvard Medical School physician, Dr. Angelo E. Volandes, Associate Professor of Medicine, Massachusetts General Hospital, and best-selling author of The Conversation, a revolutionary plan for end-of-life care. Dr. Volandes believes that a life well lived deserves a good ending. In his must-read book, Dr. Volandes proves that what people with serious illness who are approaching the end of their lives need most is not new technology, but one simple thing: the conversation. Aloha, Dr. Volandes.
Aloha.
I want to say thank you.
From Hilo today.
Yes. Thank you so much for joining us and taking your time out of this beautiful day. Without further ado, I will hand the virtual microphone right over to you, Dr. Volandes.
Wonderful. Good morning, everybody. Aloha. I truly am in Hilo. I didn't mean that facetiously. I'm here in Hilo this morning, and it's a real pleasure to be back. And so I think I only have 20 minutes. Is that right, Lani? Tisha? 20 minutes, just so I know what my time is. So 10:26. Great. I was hoping today, it's my first time in Hilo was in 2013. A long time ago. But since then, we did a large project here in Hilo, and I wanted to share first the story about how that project came to be. Then I want to talk about the project itself in Hilo, and then talk about how that project has really gone across the country. The one thing that I noticed about Hawaii, by the way, this is probably, I think, my 51st time in the state, probably my maybe 20th time in Hilo. But when I first came here, and I still think there is this perception among people in the state of Hawaii that a lot of the good ideas start on the mainland and end up in the state of Hawaii. And I really want to make the argument that it really is the other way around, that a lot of the best ideas are birthed here in the state of Hawaii, and specifically in Hilo, and that those ideas are tested, tried, and then the rest of the country catches up and really disseminates those ideas. So that is really my goal today. First, to tell you a story about how I came to this. Second, talk about how that story inspired or was birthed in the state of Hawaii and specifically in Hilo. And third, talk about how this work has really disseminated throughout the country. And so as we think about the future, especially during the time of a pandemic, don't look to the mainland for ideas. Look amongst each other, look for ideas here in the state, and specifically in this wonderful, wonderful place called Hilo. So I'm going to try first to share my screen. And go ahead and do the chat box. I love keeping track of the chat as I give the talk. So let me make sure if I can get a thumbs up that you all see my slides.
Oh, yeah.
All right. Do we see it? We're good.
Oh, yeah.
All right. So I'm going to start with the story. Some of you have heard this story, but it's really important because I think it brings me back to why I do the work that I do and how I ended up coming here to Hilo. So my story begins with this woman. This is Professor Helen Thompson. She was one of this country's foremost literary critics on the poetry of Walt Whitman. I don't know how many of you are familiar with the poetry of Walt Whitman, but when I'm not in Hilo or at Boston, I was born and raised in New York City, where Walt Whitman spent the first half of his life. And so every other street corner had a Whitman elementary school, and all the pupils were forced to memorize the opening lines of Whitman's magnum opus, The Leaves of Grass. So Professor Thompson and I hit it off because we could both recite those lines. I celebrate myself and sing myself, and what I assume you shall assume, for every atom belonging to me as good belongs to you. Now, you may be asking yourself why I'm telling you about Helen Thompson or the poetry of Walt Whitman. Well, what I haven't told you is that Helen Thompson was my patient over a decade ago. What I haven't told you is that Helen Thompson was an older female with widely metastatic cancer being admitted to my medical service. What I haven't told you is that Helen Thompson was dying. And so on that day, I did my H&P, my history and physical, but then I got to that part in the conversation where all clinicians get a little bit uncomfortable with. And that's when the words of Whitman metamorphosed into other words like CPR, breathing machines, goals of care. And so I looked at the professor and I said, Professor, you have seen scores of other doctors before ever laying eyes on me. This was the first time that I was meeting the professor. And I asked her, surely someone has started this conversation with you. She had seen oncologists, pulmonologists, primary care doctors, and I was sure that someone had started this conversation with her. And unfortunately, not a single clinician had ever started having this conversation with her. And this is a woman who was in the advanced stages of metastatic cancer. And so I did my very best. I started my conversation. I said, Professor, let's have a forest from the trees perspective. Let's talk about what is important to you. What are the risks and benefits of all these interventions? But I really wanted to know where she was on her journey with this illness. And so she gave me that blank stare that I think far too often patients and families often give us when we start this conversation, often at the worst time, which is when people are critically ill, sick, and in the hospital. And that's when I naively asked her, I said, Professor, would you mind taking a walk with me to the intensive care unit so I can show you some of these things? Of course, she obliged, but didn't walk to the intensive care unit. I put her in a wheelchair, rolled her down to the intensive care unit, got to show her a breathing machine, got to show her a patient on the breathing machine. And what the professor was able to do was to get a sense of the place, to hear the beeps and buzzes, see the colorful monitors, feel the rhythm of the intensive care unit. Now, as fate would have it, I obviously didn't plan on this, but there was a code blue in the ICU. And that's when I immediately whisked the professor out of the intensive care unit, but not before she caught a few glimpses of CPR. When we went back to her room, she looked at me and she said, words, words, words. Angelo, I understood every single word that you said before. CPR, breathing machines. I am, after all, a professor of English. But I had no idea that's the sort of thing that these things look like. Doesn't look like that on television. And that's when it occurred to me at a relatively young professional age that so often in healthcare, many times clinicians, specifically doctors and nurses and social workers, we have these conversations with our patients, but we as clinicians know what the reality looks like. But for a lot of our patients and families, they're just thinking about what they see on television, where everybody survives CPR and where the miracle cure for your cancer, according to the evening news, is right around the corner. Well, unfortunately, the clinical reality is very different. And so I began taking all my patients with advanced illness and their loved ones on tours of our hospital. Sometimes I would bring people to the intensive care unit. Sometimes I would bring people to the dialysis unit. I even brought people to our inpatient hospice unit, which was state-of-the-art back then. And what people would tell me was that this was the most powerful and empowering experience that they had ever had. They couldn't imagine making a decision about care at the end of life without my tour. Now, the nurses loved what I was doing because they saw the educational value in it, but they quickly put an end to my tour business because I was breaking patient confidentiality. And so here's the conundrum that I was left with. How could we recreate this powerful and empowering experience, but not just for my patient, not just for my hospital's patients, for patients all around the country? And that's when a group of us came up with the idea of creating short, easy to understand videos to help patients and families navigate this healthcare system. You know, we have created a healthcare system that is so hard to understand, so hard to navigate. How could we expect people to make truly informed decisions when they don't even know what it means to be a patient in a hospital today? And so that's the idea. How can we create these short videos to help people better understand their options for medical care, to get the type of medical care that they want and that they deserve. So that's the story behind the use of the videos to promote advanced care planning. And now what I wanted to do was, that was just an idea. We had a few small studies at MGH, which is known as Man's Greatest Hospital. Just kidding, everybody should be laughing on the Zoom. It's Massachusetts General Hospital. But here's the paradigm that I'd like you all to shift, because the truth is that it is a great hospital, but I think people think that all the great ideas in the world come from the great hospitals, and that's not necessarily the case. Yeah, a lot of great ideas, but how do you take an idea and really start having it in action in the real world? And that's where my personal journey begins, with the state of Hawaii and our work specifically here in Hilo. And I'm going to refer to it as the Hilo model. How do you take a good idea, but put it into practice? And I'm actually going to share with you some of the data. I don't think many folks on the Zoom are aware of the data here in Hilo, but then really talk about how that data has inspired work all around the country, and that work that was done here from 2013 through 2018 has not only impacted the community here in Hilo, but is impacting people all across the country. How a relatively small place like Hilo, where an idea was shown to be helpful, can impact not the lives of just a few hundred or a few thousand, but millions of people around the country. And so that is my hope. I'm just going to check the chat because I always see what people put in the chat. So the story begins in 2013, and I was invited by this person that I didn't know. Her name was Dr. Ray Seitz. She called me up and she said, I read about some idea you had. Can you come and give us a talk in the state of Hawaii? So I actually came in 2013 and met Dr. Seitz, hadn't met her before, had heard about her, but gave a talk. And it actually began with the same story that I began here with the professor. And she said, I really want to try something different. I want to think out of the box. I'm kind of, something really innovative. And she said, what we're interested in is taking your idea and spreading it across the entire state of Hawaii. And I said, okay, that's interesting. I really didn't think of that sort of scale. But, the other thing that Dr. Seitz and the honorary Dr. Robert Eubanks, who worked with Dr. Seitz, told me was, we really have to think of a concentrated place where we can collect data, because it's not just good enough to have an idea, but we have to have data to show that it's the right thing to do. And the place that they wanted to focus on was Hilo, specifically Hilo Medical Center, and the community here, especially the primary care clinics. And we had a huge champion in Dr. Linda Dolan, who is just a phenomenal colleague to work with. And so we were interested in is if we took the idea of prioritizing the conversation, of being able to show videos to families here in Hilo, what might be possible? What might be possible if we all prioritized having this conversation? And so over the many trips that Dr. Seitz, the honorary Dr. Robert Eubanks, and I made, and with frequent conversations with folks at Hilo Medical Center, and of course, Dr. Dolan's clinic and all of her staff, over the course of 18 months of having these conversations, we were able to show some really amazing things. What we did is we looked at, and you should be able to see this on my screen. I know Lani and Tisha will tell me if you don't. We looked at the 43,000 people back then who in 2013 through 2018 who comprised this catchment area, and we'll just in Hilo. And what we were interested in was, at Hilo Medical Center, how did documentation change over the course of time? And what we found was by prioritizing the conversation using videos, we found that there was a 37% increase in documentation of people's wishes. And that is an astounding figure. You know, in healthcare, if we see a couple of percentages increase in something that we want, we're thrilled with it. And here we had a 37% increase, which is unbelievable. And I think it has a lot to do with the staff at Hilo Medical Center. There was a wonderful CEO and CMO, Dan Brinkman, Ted Peskin, who were just phenomenal supporters of this. But the real secret sauce was Irene Iwata, who is a wonderful nurse there, who really championed this program and making sure that all people admitted to Hilo Medical Center who had a serious illness had an opportunity to watch a video and have a conversation and to document. I think that's so important. It's not enough to have a conversation. It really is important to have documentation. And I had really a wonderful conversation with Charlene and her group right before this, and to hear about all the wonderful documentation that they are promoting throughout the community. Anyway, so we saw this 37% increase in documentation, but what was remarkable was that there was also a decrease of 15% in hospital deaths. And that's a really important number because we know that most people don't want to die in the hospital when they have an advanced illness. And so to be able to show that having conversations led to decreasing hospital deaths, and then the question that all of us were asking, well, where was everyone dying? What kind of support were they having? And that's when we saw this dramatic increase in hospice growth right here in Hilo, which was really reassuring. So this is the Hilo model where people like Irene Iwata and Dr. Dolan in her clinics were promoting people having the conversation, sharing with them videos to help them and their families have this conversation, and really helping people get the type of medical care that they want when they have a serious illness. At the end of the day, that's what this is all about, is making sure people in the community get the type of care that they want. So that was a few years back, but since then, the Hilo model has been expanded widely. So the National Institutes of Health sponsored another study looking at a very similar, the Hilo model, but at MGH, at man's greatest hospital. Here was the reversed Massachusetts General Hospital, where we took an idea that was birthed here in Hilo and said, let us bring this idea back to Boston, to my hospital, and see what sort of results we had. And so what we did is we did a trial where we split people with cancer into two different populations. Some got the video, others did not. And what we did is to see what the impact was on hospice use. So if we look here at the people who saw the video and had a conversation versus people who didn't, we saw that people with, and these were patients with advanced cancer, 85% eventually started hospice, whereas without that conversation and video, only 63%. Here's the dramatic, the sort of amazing thing was that hospice length of stay, so the number of days that people were on hospice, quadrupled. People who had a conversation and saw the video, it was 12 days versus just 3 days in the other group. And so again, dramatic findings based on the Hilo work. That was only the beginning. So the NIH has now funded over 10 trials, taking the Hilo model across the country, over $30 million. These are all active trials. Our first one was advanced care planning in COVID. This is now being conducted in the largest healthcare system in New York State, where they are doing exactly what Irene did at Hilo Medical Center, but across their hospitals. The other studies include video KD, video images and diseases and ethical outcomes for people with kidney disease. Here, we're showing videos and having conversations with patients before they start dialysis. The Hilo model is being extended to the emergency room. We actually started showing videos in parts of Hilo, at the ED in Hilo Medical Center with the residents and I believe some of the scribes And now we are doing a study in emergency departments across the country. We have an NIH study that is actually PCE, palliative care educators, where we've created positions just like Irene's position, where people are dedicated to showing videos and having conversations in the hospital with all patients. And then we have another study, ACP Peace, which is in patients with cancer. And finally, ACP Home, which is really connecting patients with their primary care providers and with hospice services at home, very much like what Dr. Dolan did, which was bringing conversations early and often. So again, my hope in this brief talk has been an idea that may have come from the mainland, but that was shown to be impactful, helpful, and important here in the state of Hawaii, but most importantly, here in Hilo, and how that idea and experience has blossomed into these very large trials all across the country. And so I'm just going to with two other large healthcare systems that have adopted the Hilo Medical Center model. I don't think Dan Brinkman or Ted Peskin ever thought that Hilo's model would be taken up by the third largest healthcare system in America, but Providence Healthcare, as well as Northwell Health, two of the largest healthcare systems in the country, took up this work. So now I'm going to end with some thank yous. I think it's very important to people to remember that these discussions and ideas blossom only when you work with the best. And this is Dr. Ray Seitz. She is a legend in my field, but I think she's also a Hawaii state treasure, but probably a national treasure. A real genius in thinking innovatively about this topic and thinking outside of the box. And I was so excited to learn that Dr. Seitz has started Hui Pohala, which is a coalition organized to bring about really amazing foundational changes and to expand palliative care throughout the state. Hui Pohala's mission is to serve as a catalyst and convener to improve access to quality palliative care for anyone within the state of Hawaii. And I truly feel that this is a game changer for the state that will bring palliative care services to all those. I think too often people who are in the know, who are empowered, are able to get these services. We want everybody to get these services, vulnerable communities, people who are traditionally the ones that we see all the disparities with. I think the pandemic has shown what that means. And so Dr. Seitz's goal is equity and justice for all, and really just a national treasure for all of us. But you know, an idea is only as good as the way you could scale it. This is the honorary Dr. Robert Eubanks, who is able to take an idea, but to make sure the logistics of the project were always possible. And so, you know, through a lot of his dedication and work, Dr. Eubanks really made this project, and he always had a Cliff Bar for me because he knows I always get hungry. So he always had a Cliff Bar for me. You can see it on the bottom right. He's also a wonderful jogger companion and always kept me on the right path during my travels. But also just a thank you to the Hilo community. That's Dr. Seitz in her second job as a makeup artist. And many of you will notice that's Frances Kalantak, who's probably on the tennis court this morning. But Frances was amazing in Dr. Dolan's office and also served as a narrator for our Ilocano video. I also need to thank Dan Brinkman, Linda Dolan, Irene Iwata, Frances Kalantak, Brenda Ho, Ted Peskin, Odetta Raposo, and Jennifer Meninga, who is now Jennifer Grun. And then finally, we always have a connection to Oahu. That's Lori Protzman, Dan Fishberg, the whole Queens family. Of course, it's Dr. Aretha Delight Davis, the CEO of the nonprofit. And finally, you know, this always ends on a good news, I think. We were just awarded a large NIH grant to create a suite of Native Hawaiian videos. And so this project is being led by Dr. Marjorie Mao, who's right here, along with Dr. Adrian Dillard, Dr. Kamaka, many of you will also notice that's Dr. Gerard Akaka, who's also a team member, and Jacqueline Kanelua, who is part of the team. Many, many, many people to thank. And so we're really excited at all the wonderful work that's going on in the state. But again, I just want to really change the paradigm of how we think about things that are transforming healthcare. The state of Hawaii, Hilo particularly, has a lot of wonderful ideas and wonderful people and the data to support it. So thank you with that. I'm going to take a look quickly at the chat. I'm also going to include in the chat a link to a video that you all can use, as well as Dr. Seitz's email. So here we go. I just want to make sure, stop the share, and I'll put the information in the chat box. I'm also going to look through the chat. Spelling, please, for Dr. Seitz and Hui Pohala. Mahalo, Jeffrey, you have Dr. Seitz's email. Yeah, Lori and Dan, absolutely. That was from Naomi. Naomi also said, yay, Robert and Ray, yes. Hey, Anne, great to be back as well. Wonderful. All right. Oh, and there's Anne again. Yes, we worked with Anne Nguyen as well. So I'm glad to see that she's on too. Happy to answer any questions, but I know I'm over my time, so I apologize. Wonderful to be back.
No problem, Dr. Volandes. You know, I really just appreciate you going into the chat box as well yourself and just reading all of them. It's really refreshing, actually. You're making my job so much easier. But we really do appreciate you. And yes, I am so thankful that you're joining us here from right here in Hilo. Want to let everyone know Dr. Volandes is open for any questions that you can put in the chat box. I did want to ask one question that came in earlier. What were some of the most challenging situations that you recall when facilitating an end-of-life discussion? If you can talk a little about that.
Yeah, that's a wonderful question. Thank you, Tisha. I think, you know, the most challenging issue that comes up rarely, comes up a lot, is that when we start this conversation, people think, oh my gosh, am I dying? Why are you bringing this up? And the challenge is that if all of us did this and normalized this, then we would all be having this conversation. It wouldn't be, as I experienced with Helen Thompson, that, you know, we started this because she was dying. But if we all did this together and normalized it, then it wouldn't be a surprise. You know, what kind of healthcare system would we have if all of us just did this because that's the sort of healthcare system we do? And I think that was the best part of the experience with the Hilo Medical Center and Dr. Dolan. Dr. Dolan didn't wait for people to get sick and do this. It was people over 55, I think, and who were coming in for a WellCare visit. This is kind of what we do. And so it was expected. Nothing special about you, although we are all special. But it's the sort of thing that we do because that's the community that we live in. It's a great question. Thanks, Tisha.
No problem. Okay, again, if anybody wanted to chat in any more questions, I think our audience is just so starstruck with having you here this morning and appreciate all the information that you have shared with us. So with that, oh, let's see, we do have one. We're always told that it is so important to bring this subject up for families and loved ones well before a health crisis occurs. Is there any advice that you have for our audience when bringing up this conversation to loved ones? It's hard to emphasize the importance without facing this situation.
Yeah, it's a great question, Anne. And so there's two things I would suggest. The first is for the parents, especially parents who have adult children, you don't want to burden your kids. And so telling them that I am telling you about this, not because I'm going to die anytime soon, but this is a gift I am giving you. I don't want you and your sister and your brothers to fight or to argue or to not know what I would want. I want this. And so it's super important to frame it like that, especially for the parents. This is a gift I'm giving you. And then the other reason, we were just talking about this with Charlene and her wonderful staff just a half hour ago, is, the COVID-19 pandemic has really changed advanced care planning. This is not something that's nice to have anymore. It's a must do thing, because all of us are at risk of ending up on a breathing machine and being in the Hilo Medical Center intensive care unit. And so we all have to have this conversation. Super, super, super important. Thanks for the question.
Yes, awesome. I have a question. What is some of the most profound discoveries that you've uncovered during your research with families relating to end-of-life discussions? I know you put up a lot of what your findings were already, but can you share a little bit more?
Absolutely. I think the most profound impactful experiences that I've had is really bringing out the humanity in this discussion. As a doctor, I am often thought to myself about how these questions impact the medical care I provide. But what patients and families continually remind me is that this is not a medical discussion. It really isn't. It's not about code status or whether or not you want to go to the ICU. It has to do with some really fundamental questions of life, which is, what is a good day for me? What brings me joy and makes me have a happy day? And what are my fears? And I think really taking out the medical part of it and bringing back the human part of it so that all of us can relate to is probably the insights that I've learned over time, is not to focus on the medical part of it, but to focus on the life part of it. It's putting the humanity back into the patient-doctor relationship.
That is wonderful. I do appreciate that as well. And just going back to humanity, we do have some questions as where they can access the video.
So in the chat box, you'll see a code, and that is it's Dr. Tam. Some of you may be familiar with Dr. Tam. She was the chair of medicine at Jabson, who narrates one of the videos. And I'll put one other link so you can access some of the videos as well.
All right, that would be really great. For those of you on Facebook Live, feel free to chat in any of your questions for Dr. Volandes. If you would like, if you enjoyed all of the information that he has shared with us today, which was amazing and really great about the conversation that we have with our loved ones, please give us the thumbs up or a heart, and feel free to chat in again, any questions or even comments. We'd like to know how we hear on that side. Or we sound like on that side. I apologize. All right. Without further ado, thank you so much, Dr. Volandes, for your time, all the information that you have given us and our attendees today. I'd like to hand over the mic to Lani.
Thank you. Thank you so much, Dr. Volandes. Oh my God, you're such a rock star. So before I let you go, because I know that we've really outstayed our welcome over here with holding you on longer, is I just wanted to share with you that when I started with Hawaii Care Choices, which was formerly Hospice of Hilo, Dr. Dolan, her first thing to me was she gave me the book, The Conversation. And so I held on to it for years, and lucky for me, I happened to be on a call that she was having with you. So I sort of just, became a hogger and just, oh my God, that's Dr. Volandes. And then I tried not to be like super starstruck, but it was too late. And then I'm so glad that I was able to reconnect with you this time. And we are going to have such a meaningful and productive weekend as we go out there and film all of the family. So thank you so much. I'll let you go now, and we will definitely connect later on today. Thank you again, doctor. Thank you so much.
Mahalo. Thank you so much.
Aloha. Okay, great. Wow. Did he just really pack it in for us? I am so excited about all of the information he gave. Oh, doctor just brought it. I tell you, I'm really, really impressed with all the information that he shared. And we are recording this, so we will continue to place this on our Hawaii Care Choices YouTube channel so that people can tune into this 24 hours from now and go ahead and take a look at. For the links and other things that Dr. Volandes shared, we will definitely have that information on here as well. So let's begin unpacking what information I'd like to share with you with regard to all of the programs that we are offering. It is such a wonderful segue to what Dr. Volandes was sharing with regard to the human side of illness, the humanity of the medical industry, which for many may not actually exist. But thank goodness, Hawaii Care Choices, and really, we changed our name largely because we added on palliative care as an additional branch of what we are offering, in addition to still keeping hospice care at the middle of everything that we do. And then, of course, our bereavement care as well. It's really about the human kindness that we bring back into healthcare, which has to and absolutely needs to reside there every day. And the work that Dr. Volandes has provided for us really keeps that top of mind for us. So let's start unpacking these 3 different programs that we have. So palliative care, quickly, just to let you know, palliative care is a very large umbrella, and it's normally for those who are dealing with serious illness and they have symptoms because they go ahead and do different treatments. So palliative care, the focus on palliative care is really, really about providing relief from all of the pain and discomfort that happens because of different treatments that people are doing. The real reason that palliative care is out there, and particularly because nobody even understands what the word palliative care means, it really means to ease, to alleviate, to relieve, and to soothe. And we all know what those words are. Palliative care was created so we can boost that quality of life, even for those who are dealing with serious illness. And so when is it appropriate for palliative care? When I asked Dr. Dolan, she'll always tell me right at diagnosis. And the reason she says that is because, people can kind of sit at the side of the pool and dangle their feet in there and kind of watch what's going on, get to meet their palliative care team and kind of understand like what their participation will be like with regard to palliative care. And so we find that when people come in early to receiving palliative care, they're already starting to make lifestyle changes that are very, very critical to their quality of life as well. So for our palliative care program, those with cancer, CHF, COPD, and advanced kidney disease are all those that will probably qualify to be in our program. And this is another interesting part, is many people didn't realize that we can serve people of any age, even children. And oftentimes people will come to see us because they're dealing with other treatments because of their serious illness. So many times those that are having chemotherapy or radiation, they normally have, some kind of discomfort, and we're right there to help them to boost that quality of life, and mainly to teach them how to live now with this serious illness and still maintain the active life that they have so well enjoyed. And it doesn't matter with regard to when people are dealing with serious illness, they do not need to have a 6-month life expectancy prognosis when they come to us, and they don't need to be considered terminal as well.
All right, there is that brain teaser. It is up on your screens right now. And the question is, the goal of palliative care is to improve the quality of life for patients and their families. Just want to let everyone know on Facebook Live, unfortunately, you would not be able to engage in the polling, but please put that comment in the box if you would like to. Feel free to give us a thumbs up or a heart if you do enjoy or have been enjoying this talk story. And if you would like to join us on Zoom presentation next month, please email me at lfukushima@hawaiicarechoices.org. Thank you. All right, with that, we're going to end our polling right there and share the results. So 100% of you say the goal of palliative care is to improve the quality of life for patients and their families is true. Thank you so much for participating in our polls. Back to you, Lani.
Thank you so much, Tish. You folks are just right on top of it. I just love when people are just fully engaging and just listening to everything that's happening. Let's move on to the next slide. Okay, so signs of palliative care. The reason I put this up is because for the most part, I know all of us are not doctors, but there are some physical changes that are happening with ourselves or our loved ones that could really help us determine, maybe I should call my doctor. So of course, if you find that you or a loved one is going to the hospital for frequent visits, or you tend to be calling the doctor like at dinner time or 2 o'clock in the morning, maybe it's difficult now to really manage the medications, largely because there's so many medications. It's really hard to really keep focus on it, and diminished activities of daily living, like managing your finances, driving, going grocery shopping, or maybe something as simple as preparing a sandwich, or even, throwing a load of laundry. And these items are becoming difficult for you to do. Maybe it's time to check in with your doctor and see if you could really be supported by palliative care. Again, other things such as pain, like chronic pain, like not pain that it just came and it went. It's like it's with us all the time. And of course, any kind of swelling in the feet and legs, feeling nauseated, and of course, always very tired. So, like I said, at time of diagnosis is really the best time. So people will say, well, I got diagnosed with cancer, but I'm not having any symptoms, so I probably don't need palliative care at this time. I tell them, no, come on in, get at least to the side of the pool. So when it's time for you to jump in, you're going to be good as gold. So we do tell people, come in as early as possible, even if they're not dealing with any discomfort, so that we can begin educating them to make choices that will be good for them. The other thing is, say if somebody comes in with congestive heart failure, and then they're saying to us that it's difficult for them to breathe, lots of times it's just because they haven't gotten the education yet of maybe Spam and Portuguese sausage every day is not where they need to go. And so as a result, we're in the home already trying to help them deal with issues of their daily living.
Lani, we have a question coming in for our attendees. Is a doctor's referral to Hawaii Care Choices necessary?
Yes, we will need a referral from your doctor. However, we do have a lot of families and patients that just call us directly, and then we go to the doctor for you. So either way, whether you call your doctor or we call your doctor, we'll make it happen for you. You won't have to worry. So what do you expect if you sign up for palliative care? First of all, you have just the most dynamic team that will come to your house. And, besides asking you stuff like, your medical history and then taking your blood pressure and all of that, really our biggest concern is what's important to you or your loved one, because this is the time where humanity thrives. We want to know what is important to you. Is it you want to go and see your grandson graduate this year? Or is it you want to participate in your family vacation to Disney World? Or is it something just as simple as you just want to get off the couch and walk to the mailbox without being totally breathless? These are the kinds of concerns we want to hear, and we create a plan of care for you. It's all about your wishes, your choices, and helping you educate yourself so that you'll be able to follow through with all of your plan. Okay, so medication review. So this is what we're still dealing with regard to the medical industry, is we often operate in silos. And so, you know, somebody could go to their primary care physician, get medication there, and then maybe there's some kind of incident that happens, so they go to the hospital, they get some medication from there, and then they're going to see their specialist, whatever ologist that they're going to, and they get medication from there. And then maybe something happens and they go to urgent care. In any case, what happens is everything operates in silos. And sadly, because of that, no one is reconciling all of the medication. And then it could be a balancing act, just like you see here on the screen. So what ends up happening is the palliative care team will come to the home and go over all of the medications and then contact the primary care physician, who is the lead on our palliative care team. And so we'll call your doctor and ask, well, this is what the patient is taking. What do you suggest? And maybe somebody is taking as many as 35 different medications. But after we do the medication review, you know, maybe they're taking only 22. I get it. 22 is still a lot of medication. However, it's so much better than 36. So we find that once this medication review is done, oftentimes at least 5% of the ailments and discomfort that a patient is dealing with goes away. And it's largely because sometimes the medication that they're taking is counteracting each other. So medication review is definitely part of palliative care. So how does it work? Well, we pretty much come to the home and we create that plan of care. Well, we're looking at where are the pain points, what kind of symptom management can we help with? We also help with care coordination, because at this point, you're normally seeing, or your loved one is normally seeing, more than one doctor. And it starts to get really hectic on, okay, you got to go to this cardiologist, and then, you know, you're going to go to your primary care, then you're going to go for a blood test. We come in and we actually help the family and the patient really get that coordinated. And then, you know, we help them with their planned care and keeping up with the different things that they need to really boost their quality of life. We'll also help them with signing up for different insurance if they need to. Like, there's times where we'll come in the home and then we'll help people sign up for Medicaid insurance if that's something that they don't have and they could qualify for. And of course, the very, very important completion of the Advanced Care Directive. And largely, it is because we want the patient to have peace, and we want to give the greatest gift of all to their family by having them have an advanced care plan. So how is palliative care paid for? For the most part, it's paid for by a person's insurance, and it could be Medicare. Somebody has Medicaid as well. There's normally no copay. The copays will range anywhere from a regular doctor's visit price, anywhere from $20 to $40 a visit, whenever our nurse practitioner or our licensed social worker comes to visit. Other than that, if people have, like I said, the double insurance, there's no copay at all. Hospice care. So as people continue on their natural progression and illness, sometimes they get to a point where now it's time for a higher level of care, and that is hospice care. So hospice care treats the person versus the disease. So the focus is really not about curing somebody. It's really about keeping somebody as comfortable as possible. I do get a lot of people that will say that they've worked at a hospital or in a medical facility, and they notice the difference. And the difference really is that other facilities will be focusing on keeping somebody alive no matter what the cost. And when somebody comes to hospice care, the entire philosophy changes, because the focus is really on quality of life, not quantity of life. And there's a huge shift in that. Really, hospice care was created to ease terminal suffering. It wasn't viewing death as an enemy, because sometimes death is really where the peace is. But hospice care was created largely to really help with all of that suffering, and then to provide the emotional and spiritual care that helps people to really mitigate some of that stress that's surrounding a time where most people find quite critical and a crisis in many people's lives. Again, for hospice care, it's all about the comfort.
Lani, I have a question again. What kind of insurance covers your services? Is long-term health insurance part of that coverage?
So is that for palliative care, or is that for hospice care?
It wasn't specified. Can you quickly go over palliative one more time?
Yeah, so on palliative care, the services of palliative care are covered with Medicare or any of the insurance out there, except for VA, Veterans Administration, or Kaiser, because both have their own palliative care programs. But all of the others, HMSA, Ohana Care, all of them, they all can be used with palliative care. And then, of course, for those who have Medicaid or Quest, there's no copay at all.
Perfect. Thank you so much, Lani.
And if there's any clarifying question that they would like, please go ahead and put it in the chat. I would love to answer that for you. So what is hospice care? So hospice care is provided by a care team for those who have terminal illness. And hospice care really is there to not only support the patient, but the family as well. So let me explain to you, like, what happens is a lot of times people don't understand about hospice care, and we'll get people that will say something like, oh, mom looks like it's time for us to call hospice care. And then the other family member will say, oh no, but mom is still sitting up. She's still eating. We still have a few more weeks to go before we call hospice. I want you to know that that's a huge mistake, because if somebody qualifies for hospice care, the benefit to the family is amazing. And it's because, you know, if somebody comes to us in the last 3 days of life, we can quickly make that person comfortable. But there's no way for us to help the family build their resilience on what is sure to be a very, very difficult time. So in my story, when my father was diagnosed with congestive heart failure, his only wish to us is if he could just pass it home amongst all of us. And we said, piece of cake, we can do that. Sadly, we didn't know about hospice care. And so when he couldn't breathe one evening, we went ahead and we called 911. They whisked him off to the hospital, and then he sadly died there before we arrived at the hospital. So for the family, it was an epic fail. Years later, my mom was diagnosed with lung cancer, and her doctor proactively said to us, your mom qualifies for hospice care at home. So why don't you let her know that she can go ahead and sign up for hospice care? Well, my mom, stoic Hawaiian woman, I mean, she was not going to hear about having hospice care. But I thought, well, I would just try it and go in and ask her. So my version of the conversation was, Mom, so I heard that you can get hospice care. And she goes, hospice care? No, I don't even like that word hospice. I can't believe that you're even bringing it up. I don't need that. I'm going to live a long time. I said, oh, okay. So I guess you're not about hospice then. No, I don't need hospice. I'm going to live a long time. I don't need that at all. I said, oh, okay. Well, Mom, you know, I heard we could get free stuff. What? Well, like what? And I said, well, I heard that if we sign up for hospice, they can, you know, bring oxygen or the hospital bed, the wheelchair. And I know you're not using all of that, Mom, but brother is already renting the wheelchair for you. So what do you think? She goes, well, I mean, if we're going to save money, silly, of course we should sign up. So of course, this is my own way of moving something that was medical focused into financial, and she went for it. But anyway, I mean, you have to do whatever you have to do when it comes to your family. So this is what happens, is she goes ahead and signs up. Now months go on, and clearly she lived well past her 6-month diagnosis. And it was largely because of the really intentioned loving care that she was receiving. And then she said to me, "Oh my gosh, this is beautiful. I'm so sad that Daddy didn't have this." And I said, "Yeah, I know, I'm sad too. I wish we knew about hospice care and all of the benefits that we get when we sign up." And she says, "You know what? You go out to all of the neighbors out here right now. You go tell them about this hospice, because they got to sign up. I know they're going to pass, they won't even know. And all of this is already included." Meaning, just because she had Medicare, hospice at home was 100% covered. We didn't spend even a dime. Oh, she just couldn't believe how beautiful it was, how abundant it was to have all of these services. So she said, "You go out, you go tell all the neighbors." And then I told her that it's a little bit awkward. I don't think I could do that, because not everyone's going to be ready for hospice right now, Mom. So anyway, she said, "Yeah, that's right. That would seem awkward, but you figure out how you're going to go around and tell people about this hospice." And so fast forward 10 years after my mom passed away, here I am telling all of you about all of the wonderful, wonderful benefits that each of you can have, and for your loved ones as well. And so I tell you, I don't do this as a job. I do it because it was a promise I made to my mother. Next slide.
That was a wonderful story, Lani. Thank you for sharing. I do have one question before we advance slides. A follow-up question with the insurance. Long-term health care coverage is usually brought from insurance companies such as State Farm. When does this type of coverage include palliative or hospice care?
So normally people will purchase that kind of insurance so they can use it should somebody need to go into a long-term care facility or nursing home. So when someone goes into a nursing home or long-term care facility, palliative care is already included as part of that program. However, hospice care can still come in and add an extra layer of care wherever they are in whatever facility. And that's what that type of insurance is for somebody to use it if they're going to a special facility.
Wonderful. Second question, is TRICARE for Life considered VA?
Oh, I'm not familiar with that one in particular, but please put your contact information there, because we'd love to get back to you so that we can verify exactly about TRICARE and what it covers.
Awesome. Thank you for answering those questions, Lani. I just want to shout out to everybody attending on Zoom. Thank you so much. And any of your questions, please go ahead and use that Q&A box on the bottom. Those of you on Facebook Live, thank you so much for sticking around and watching with us. Lani is unpacking a whole bunch of information, and she is definitely going to share another story in a little bit. So please like or share your reactions with the heart, and share this video with anybody that you think may need this this information as well, because like we know, it is never too early for the conversation. Thanks.
Oh, I see we got another question from Alan. Thanks, Alan, for sending that in. So hospice care is does not cover in a facility. So it is either going to be covered by Medicaid or it will be private pay. So we're going to come up to a slide that covers that, but I just want to answer for you that hospice care at home is covered 100% on Medicare. However, if you go into a facility, then hospice care is separate from the room and board of that facility, which is normally covered by either private pay or Medicaid or Quest. Thank you, Alan, for that question. All right, here we go. who qualifies for hospice care? Again, you know, you don't have a medical background like me. I have no clue, but I can notice if somebody is physically suffering. So in order to qualify for hospice care, the person has to have been diagnosed for a terminal illness by their primary care physician. Their doctor, believe me, is doing just the best possible on giving a guesstimate of 6 months to live. And then the patient is no longer seeking curative treatment. So they're not going for dialysis or chemotherapy or any of that. They just want to focus on being home with their family and just staying comfortable.
All right, another brain teaser. It is up on your screen now. The question is, hospice is where you go in your last days. True or false? Excuse me, thank you. For those of you on Facebook Live, if you would love to just thumbs up or heart, you can even enter that comment right in the comment box. Hospice is where you go in your last days, true or false. There are no right or wrong answers. We just love to know that you guys are continuing to be with us. So thank you. I'm gonna go ahead and end the polling right there and share results. So hospice is where you go in your last days. 18% of you said true and 82% of you said false. Thank you so much again for joining in on our polls. Go ahead, Lani.
So I just wanted to unpack that a little bit about where people go in their last days. And I'm going to share with you the truth of the matter is that people need to come to hospice care when they are diagnosed with a terminal illness. So the sooner they come to us, the better it is, not only for them with regard to how much quality of life we're going to boost into their life, but so their family can build their resilience as well. I'm going to tell you a story and you go ahead and give me a thumbs up or a heart, or even raise your hand. And for those of you who are on the Zoom, that hand is over there in the participants panel. But really, what ends up happening with regard to those who wait until late before coming into hospice, it's like, I liken it to a level of service. So let's just say all of us are going on Heaven Airlines. Some of us are going to go at 12 noon, others will go at 2 p.m., and others will go at 6 p.m. Make no mistake, at some point, all of us are going on Heaven Airlines. The destination is already determined for us. Okay, so for those who are on hospice care, they're going to come into the airplane and go directly to the first class cabin. And the reason they're going to go to the first class cabin is because that is where all of the comfort resides. And they're not only going to go with just the patient, the whole family is going to go up there. And for the rest of the people that come onto the airplane, for whatever reason, they didn't sign up for hospice because they didn't know, they were afraid, whatever the situation is, they sadly do not go into the coach section of the plane. They actually go into the baggage compartment of the plane. And the reason they go there is because it is the toughest, the most horrific, bumpiest, coldest ride all the way to the end. And although their loved one does cross the rainbow and go to heaven, they have to return on that horrific ride back. And once they get back, many of them have broken into a million different pieces, which is so very, very difficult for us to try to help them piece everything back together now that their loved one is gone. So if this is something that you would like to avoid, I'm saying to you, please get on hospice care as soon as you can so you can help your loved one. Or if it's for yourself, you can ride in comfort all the way to the end. Next slide, please. All right. So, thank you so much. I'm seeing that you folks are responding. Yes, please definitely respond. I love to know if you can relate to the things that I'm saying to you. Go ahead and give me the thumbs up. We're looking for all of that, or give me the hand raised right there on the panel. Go to where it says participants and just raise your hand so we know that you are hearing us. So when it's time for hospice care, basically, again, just from a physical standpoint, you start to notice that if you or a loved one tend to go to the hospital a lot, or you're calling the doctor a lot, maybe even losing the stability, like becoming a lot more frail, so falling down a lot, not eating very much or drinking very much, having a difficult time getting out of bed or even out of a chair, and only wants to sleep most of the time, just wants to sleep, difficulty in staying up. And then, of course, there's like skin infections and other infections that are happening across the body overall. These are definitely signs that maybe hospice care would be appropriate. Okay, so how does it work? And again, if you have a comment, please put it there in the chat, or raise your hand there on the panel right under participants. And of course, anybody that's on Facebook Live, please let us know what your comments are. We look forward to hearing from you. So the hospice care team will go to the home, just like our palliative care team. We'll go over the plan of care. And again, the humanity of it all is just learning what is important to the patient and the family, and creating a plan of care just based on that. And of course, for hospice, like I told my mother, all of the equipment, medications associated with the diagnosis that someone goes into hospice care is all included. And a person, should they decide, can of course keep their primary care physician. So when somebody signs up for hospice care, the team comes to the home. You start to really bond with your team, because the team really is taking all of the data with regard to, your temperature and all that, but they really just care about you. They just want to know what's important to you. And this is the part that they love the most, is that it's really your choices, it's your wishes that drive us to, surround you with all of that care. And that's really how we determine how often we come to see you, and the kinds of things that not only you, but maybe your family need to be supported during that journey.
Yay, there is that brain teaser bell once again. It is up on your screen. The question is, my culture expects me to take care of my family with healthcare needs at home. Strongly agree, agree, neutral, disagree, or strongly disagree. I want to shout out to all of those on Facebook Live. Thank you so much for joining us and tuning in to our healthcare talk story. If you would like to answer this in the comment box, feel free to join in on answering the poll that is up on our screen on Zoom. But you could also feel free to share, thumbs up, heart, or even share this video with those you think will love to hear this information as well. Thank you. Okay, for all of those on Zoom, I see you guys are just getting everything in. I'm going to end the polling right here and share these results. So my culture expects me to take care of my family with healthcare needs at home. 17% strongly agree, 42% agree, 33% are neutral, 8% disagree, and 0% strongly disagree. Again, thank you so much for joining in and just sharing our polls. Thanks. Back to you, Lani.
Thank you so much, Tish. So for those of you that can hear this presentation. You know, a lot of times culturally, we are raised to believe that it's time, when it's time that one of our loved ones becomes sick, that it's our responsibility to take care of them. And as a result, we feel shame if we have to reach out for any help. Go ahead and put out a heart or a thumbs up, or even give me a raise of the hand if you believe that to be a much better daughter, a much better wife, a much better sister, a much better father, that by asking for help, by allowing us to come in and help you and your family, that it just allows you to be that much more of a better daughter, of a better wife, of a better son, by getting that support. So there's no need for you to feel embarrassed about reaching out for that help, because this is probably the toughest time in anyone's life. And it's really important to know that there is help out there. You simply need to ask for it. Go ahead and give me a thumbs up or a heart if you can hear that, and if that's what resonates with you. Next slide, please.
Lani, before we advance, I have a wonderful question. I have been my mom's full-time caregiver for over 10 years. She is happy here. She is 99 years old and going through expected changes, but I realize now that I need to get professional nursing training for myself so I don't unintentionally injure her by not moving her correctly. Is there such a training program for caregivers offered by Hawaii Care Choices?
We don't actually have a training that's separate from any of our programs. However, it might be good to just see if mom could thrive on palliative care, because when our team comes in, part of the education on taking care of your loved one is included in that. And why I think your question is so vital is because a lot of times our caregivers will tend to decline in their own health and get hurt as well when they're moving their loved ones, you know, turning them in bed, etc., hurting their back and all of this other stuff that caregivers are often overlooked. And I'm so glad you brought that up, because it is really vital. We find that there are times that our caregivers tend to decline at a much faster rate than the patient themselves. And it's because, you know, it's so exhausting at times to be caring for someone that oftentimes the caregiver forgets to, you know, eat or get enough rest. And that's where injuries can certainly happen. Thanks so much. And if you hear this and that resonates with you, give me a thumbs up on Facebook, or raise your hand in the participants panel so we know that this means something to you as well. Thank you.
Yes, and we are so excited that we have all of our attendees bringing in questions and comments. Lani, can you please share how your team recognizes and helps with caregiver burnout? And do you provide respite care?
So on our hospice care program, we definitely provide respite care. And the respite care is provided here at Pohai Malama Care Center. And it's normally up to 3 days. But yes, we definitely provide that for any patient family that is on hospice care. We also provide trained volunteers to help with the caregiver. And so what happens is normally we will send a trained volunteer to the home to give the caregiver a break. And, you know, it could be anywhere from 2 to 3 hours every week for the caregiver to either rest, you know, go clean the yard, go run errands, whatever that caregiver needs to do, to really just kind of take a moment to be away and gain perspective again. And we are always so patient when we ask the caregiver if they would like somebody to come in and give them some support, meaning we would send a volunteer there. many times we will get people that will say, oh, no, I can take care of my husband myself. You don't need to come. But we'll keep pressing upon them because it's their support and health that we are looking after as well. And by the time they allow us to come in and bring our volunteer, they'll just say, oh, I can't believe that I went without this for so long, because it does make a difference and it makes them a better caregiver. So yeah, although we don't have a separate training school or anything, we will provide that education as part of our hospice benefit. So here, what I just wanted to mention to you that on our Pohaima Lama, that this is where people will come if they're at home and they have uncontrolled symptoms that cannot be controlled at home. Then they'll come to Pohaima Lama, which is located here in Hilo. This is a state-of-the-art facility that we are so very proud of. But people do not come here for long-term care. They come here because they are dealing with uncontrolled symptoms. And so once we get those symptoms under control, we will either send them back to their loved ones at home, or they will pass here. I'd say the highest percentage of people that come to visit us here will normally pass here. And all of their hospice care is covered under the Medicare insurance. However, room and board is not covered. And so that is where people will normally use their second insurance, such as Medicaid, or they'll opt for private pay as well. So hospice care is paid for 100% by Medicare at home. Kaiser, all the private insurance companies are part of this, including Veterans Administration and Medicaid. And then again, private pay for room and board, that's the only thing that's not included if somebody needs to go to a facility for additional care. Any questions out there?
Not at this moment, but the comments are just flowing in. Thank you for sharing all your information and your stories, Lani. Thank you.
Okay, great. Yay, yay. So I'm hoping people are out there hearting or giving us the thumbs up. If there's some information that I'm sharing with you that's really resonating with you, let us know, because we want to keep giving you all the information that we can support you with, and we'll keep doing this every single month. So what does the trained volunteers do? I tell you, a lot of times our patients bond so well with our volunteers that they refuse to go from one program, say as they transition over from palliative care into hospice care. They only want to go if their volunteer goes with them too. So I'm just saying, the volunteers, they really give witness to the human side of the illness progression, that they are there for the patients. They see them, they hear them, they're for them there. And they also recognize and validate the support and care of the caregiver as well. And that's why the volunteers are so very vital to the success and support of our programs here. So bereavement, I was telling you about the airplane ride for all of us, and that at some point we have to come back, and depending on, what class of service we went into, we may come back needing a lot more support. And so with regard to bereavement care, anyone that is on hospice care, know that the family will get 13 full months of bereavement support from our team after the passing of their loved one. And I also like you to know that with regard to anyone that loses somebody unexpectedly through maybe a car accident or some illness, and they need support with bereavement, we still are conducting our community support groups that meet over Zoom every Tuesday at 10:30. So definitely please join us. And we're doing children bereavement over Zoom as well. So this is our mission. This is our mission. And this is the area of service that we provide from Lapahoehoe to South Point. And our mission is to improve the lives of those we touch by offering support, guidance, and compassionate care of body, mind, and spirit. So really, our focus is on improving the lives of those we touch in any way we possibly can. And so if this is something that resonates with you, go ahead and give me a thumbs up, heart this, because hospice care is really what we want to bring, as well as palliative care now. We're so excited that we are able to do that. And look at the whole area that we cover, all the areas that we cover on the slide in color, from Lapahoehoe to South Point. These are the areas that we will drive through no matter what time of the day or night to come out and support and help our families. This is where you contact us. You can call us directly, or you can email us, or you can just go to your doctor, because your doctor will be able to connect with us and provide you the care that you truly need. This is the reason that we do these presentations, is because we found that, you know, if the doctor only sees you once a year, it's difficult for him or her to know the changes that you're going through. However, in describing the different changes that you can see, that you can feel, maybe you can be proactive and in charge of your own health care. That's really the permission I'm giving you today, is for you to be in charge of your own health care, so that you call us and let us know, hey, I could use the help, or hey, my uncle needs this help. This is what I find too, is I find that the younger generation, those that are in school, high school or in college, they're the ones that are often making a lot of the decisions, or at least bringing up a lot of the questions within a home, where they will say in a multi-generational home, hey, Mom, I think Grandma could use these services. I heard this over Zoom at my nursing class, or I heard it at my other class at school. Maybe they could use this too. And so it doesn't matter what age somebody is when they hear this information. Just go ahead and give me a thumbs up or a heart if that resonates with you, that in your family, you are actually the mover and shaker, irregardless of your age, because we find that a lot of the trendsetters are happening from those who are in high school and college, that are just reminding Mom that I think Grandpa could use this service, and please call 969-1733.